Thank you. Hopefully everybody, everybody can hear me. So that is what we're going to talk about for about the next hour. We're going to talk about some issues associated with prescribing controlled substances for pain management. We're going to look at some of the ways that providers get into trouble when prescribing opioids and narcotics for pain management. And we're going to talk about some risk management strategies for improving safety and reducing your liability exposure in this area. And I want to point out this is not a clinical course. We're not going to talk about which drugs you should prescribe or how much of something you should prescribe. We're going to talk about the risk management strategies that you can implement that will help reduce the potential risk associated with prescribing opioids. So let's start with a little bit of background on this. Pain, of course, is very difficult to measure. It's a multidimensional phenomenon. It's very subjective. There might be some physical findings, but each patient perceives it differently. And back in the 1990s, there was some recognition that treatment of pain was often inadequate. And there was a big push to provide better pain control for all patients, cancer patients as well as non-cancer patients. And the philosophy changed. We were basically told, don't worry about addiction, it's a rare thing. As long as the patient's really in pain, you can prescribe much more of these medications. And there was a concern for undertreatment. There was a case in California, a big case in 2001, where a physician was found negligent and liable for elder abuse due to inadequate treatment of a dying cancer patient's pain. And that case got a lot of attention in the medical community, and it helped shift the focus into prescribing more of these pain medications and helping patients control their pain. There's been some interesting studies on the amount of pain medications that are being prescribed. One study found that the number of opioids that were dispensed by retail pharmacies in the U.S. nearly tripled between 1991 and 2010. So where are we today? Now today we're having growing concerns, and the focus has gone to being on opioid misuse and abuse. We certainly have an increased understanding of these medications. They carry more risk and require more monitoring than perhaps was once thought. And some sources are suggesting that just prescribing more pain meds isn't really the answer, that oftentimes just spending a little bit more time with these patients can have the same effect as prescribing more pain meds. Some other statistics that I turned up, 116 million adults live in chronic pain, and more than 8 million use opioids for pain relief. And another item that I thought was really interesting, the United States has 4.6% of the world's population, but consumes 80% of the world's opioids. And that's pretty phenomenal. And between 1999 and 2006, the fatal poisonings involving opioids more than tripled, from 4,000 to almost 14,000 deaths. In prior years, before opioid abuse became such an issue, heroin was really the drug of choice on the street. Prescription drugs were not really viewed as bad as street drugs. But deaths related to opioid pain relievers are now a significant public health threat. A recent FDA statement indicated more than 16,000 lives are lost each year due to opioid-related overdoses. And according to the CDC, and this is what the slide is illustrating, more people die from opioid overdoses in the U.S. now than from cocaine or heroin overdoses. And the information that the CDC has also indicates that women are more likely to have chronic pain. Women are more likely to be prescribed prescription painkillers, to be given higher doses, and to use them for longer periods of time. They've also found that women are more likely to become dependent, and they're also more likely than men to engage in doctor shopping, to go from physician to physician, to look for more prescriptions, bigger prescriptions. Deaths attributed to drug overdose is still higher among the male population than it is for women. However, 5 times as many women died from prescription painkiller overdoses in 2010 than died in 1999. And the number of deaths during that time period from 1999 to 2010 has been put at about 48,000. So let's talk a little bit about what the risks are for you as a physician in prescribing these medications. The risks really fall into 3 categories. You have professional liability, and that is a civil case. We're talking about medical malpractice there, where a patient or a patient's family, if the patient has died, sues you and alleges that you as a physician were negligent in prescribing this medication, that either your actions or your inactions fell below the standard of care, and that's the professional liability risk. You also have a regulatory risk when prescribing these medications. At the state level, the State Board of Medicine can start an investigation. They will look into, they'll review the record, they'll look into the case, and the findings might lead to formal allegations being made, formal charges, and remedial actions being taken by the state board. The worst case scenario could even be the loss of license. And then at the federal level, you have the DEA, and they're the ones that will investigate physicians when there are allegations of wrongdoing. And that can typically result in the revocation of your DEA number, which prevents you as a physician from prescribing these medications. And that can also lead to the 3rd level of risk. That's criminal prosecution. Now, criminal prosecution is rare. We certainly see it much less frequently than medical malpractice actions or state board or regulatory actions. But it's a rapidly growing risk for physicians. And a lot of times when you look at the criminal cases, they really are fairly egregious situations. You really begin to question whether the physicians involved really are practicing medicine. And they certainly make a big splash. They're always, they're in the news. They give a lot of bad publicity to physicians. But it is another risk that, as a physician, you might face. So let's talk about professional liability first. The allegations that are typically made against physicians in a professional liability case, that the physician's fallen below the standard of care, they're based on several different theories. One is negligent prescribing, where multiple medications were prescribed together or excessive medications were prescribed. Another is negligent monitoring, where the allegation will be made that the physician did not monitor the patient adequately or appropriately while the patient was taking these medications. Other allegations made against physicians would be failure to consult or failure to refer the patient. Similar meanings there, but essentially physicians who do not send the patient to the appropriate specialists and consultants, who don't refer patients to pain management specialists, to orthopedic surgeons, physicians who suspect that patients are abusing their medications and don't refer the patient or have a conversation with the patient about drug abuse and possible rehab. And by saying that the allegation might be failure to consult, I'm not suggesting that in every single situation that you must send the patient to a specialist or that you must have a consult, but there would certainly be times when that would be appropriate. So I'd like to start out by looking at a case in the professional liability arena. And this is a case from our own claims experience at NorCal, which is the parent company of Medicus. This was a 43-year-old female patient who in May presented to her family practitioner complaining of severe lower back pain. And she reported to her family practitioner that she'd been seeing a psychiatrist for depression and anxiety, and for that she was taking multiple medications, which are listed here. So she was taking risperidol, Desaril, Lexapro, Valium. She was already on these medications. Her family physician referred her to an orthopedic surgeon to be worked up for this back pain. She went to the orthopedic surgeon, so she saw the consultant the next week, and he diagnosed her with degenerative disc disease, and he prescribed 15 milligrams of oxycodone to be taken twice a day. The orthopedic surgeon continued to treat the patient for her back pain for 8 months. And over the first few months, he gradually increased the dose until the patient was taking 30 milligrams of oxycodone twice a day. So in January, 8 months later, the orthopedic surgeon refused to continue prescribing the medication for the patient because he felt that she was abusing the meds. So the day after she went to the orthopedic surgeon and couldn't get her prescription, the patient went back to her family practitioner. She told the family practitioner that the orthopedic physician would no longer prescribe the meds for her, but that she still had constant and severe back pain. So the family practitioner prescribed a number of things for her. He prescribed the 30 milligrams of oxycodone to be taken twice a day, and he ordered 45 pills. So we're going to do a little math as we go through this. That should have been a 22-day supply. He added hydrocodone for her continued severe pain, one every 4 hours as needed, and he ordered 150 pills, so that was at least a 25-day supply there. He then increased her diazepam and gave her 90 pills for that. Now, this is a medication that the psychiatrist had been prescribing, so he increases that medication, and he refills her other antidepressant, anti-anxiety medications at that time. So that's January the 5th. About 2.5 weeks later, on January 22nd, the patient calls the family practitioner's office, and she reports that she's gone through all her oxycodone, and she requests an increase in the prescription. Without seeing her, the family physician prescribes 90 pills of 30 milligrams of oxycodone, and he tells her that she can take it up to 3 times a day. So at this point, we're now adding at least another 30-day supply if she takes it as prescribed. 5 days after that, she calls the physician again, and she requests a refill of her hydrocodone and the diazepam. If we remember our math, the hydrocodone would have been due at that time, but the diazepam that he gave her on the previous visit should have lasted her until mid-May, and she's required a refill. She's requested a refill in the end of January. 10 days later, the patient calls the family practitioner's office and claims that the oxycodone fell out of her purse and was lost. And let me tell you, if you prescribe pain meds and you have a problem patient, if you've heard this once, you've heard it 1,000 times. And the family practitioner prescribed another 130 pills for her. So just for perspective, in a 32-day period, this patient received 265 tablets of 30 milligrams of oxycodone. And at her current prescription levels, she should have needed about 96 at most if she took them every time that she could according to the way the prescription was written. And this is something that I would ask you as physicians and prescribers to think about. In your medical record and how you document the way you prescribe to patients, are you easily able to identify when the last time you gave a prescription to the patient and how much you gave the patient? Because I do wonder in this case whether this physician was even able to identify that in a medical record. And as a risk management professional, one of the things we do is risk assessments in physician offices. So we go out and visit physician offices, and we will look at their processes and medical records. And it sometimes surprises me to see in a physician's medical record that I cannot identify how much and when a medication was actually last prescribed for the patient. And that's a really important point when you're prescribing opioids for patients. You need to be able to identify this so that you know when the patient calls you that it is weeks too early for the patient to be asking for this, and that is a red flag. On February the 15th, the patient contacted her psychiatrist. She requested treatment for addiction to oxycodone, but unfortunately later that same night she hanged herself, and the patient did die. So there was a wrongful death suit brought against this particular family practitioner. Her husband and children brought suit. And as always happens when there's a medical malpractice suit, people review the record and expert opinions are sought to see where you stand. How is this going to play out in court? What are the issues going to be? And when the experts reviewed the records and looked at this case, there really were many issues. And this is a pretty extreme case, but it is something that actually happened. The issues included things like this physician failed to communicate with the patient's other treating physicians. So he never attempted to communicate with the patient's psychiatrist. He never communicated with the orthopedic surgeon. He was treating this patient's back pain without performing any type of diagnostic examination. So I'm not even talking about diagnostic tests. He did send the patient to an orthopedic surgeon. There were most likely some tests done. Something may have been done. But this physician never really even did a physical examination of the patient. He prescribed excessive quantities of the narcotics. The experts felt that he added additional narcotics when they weren't indicated or justified. He failed to refer the patient to a pain management specialist when her pain seemed to be escalating, and he could not identify a good reason for that. And he failed to consider, to screen for, or to suspect narcotic addiction. And as a result of that, failed to refer the patient for any type of treatment. Another thing that happened with this particular case was that the documentation was very poor. And I don't know if any of you have been involved in a medical malpractice case, but one of the things that really helps support you as a physician is the documentation. And without the documentation, it becomes very difficult to defend a physician. Even when you meet the standard of care, if you can't find supporting documentation, it makes it very difficult to defend. Some of the documentation problems in this case was that there was no indication that this physician reviewed any prior records or even tried to obtain them. There were no physical exam results in the chart. There was no quantitative assessment of the patient's pain level. There was no indication that the physician had discussed opioid addiction. No pain medication contract or agreement was in the record, and we are going to talk about that in a little bit. No evidence that the physician assessed the patient for the effectiveness of the pain med. There was no rationale for his choice, no copies of the prescriptions, so no record of how often or how much of these meds he actually prescribed. And that lack of documentation really corroborated the plaintiff's allegations about the mismanagement of the patient's pain. And during litigation, that lack of documentation really made it difficult. It actually made it difficult for the physician to recall what he was thinking at the time that he was treating the patient, because one of the other issues with a med mal case is that it doesn't come about right away while you still remember the patient. It comes about years later, and you may not have a particular memory of the patient. So for all of those reasons, the negative standard of care reviews, the causation reviews, the lack of documentation, the case did end up being settled with the physician paying to the plaintiff. From a regulatory standpoint, the concerns that you have here are with the DEA, and they do work very closely with the state licensing boards and state and local law enforcement. Essentially what the DEA looks for is that they want to ensure that controlled substances are prescribed, administered, and dispensed for legitimate medical purposes and in accordance with federal and state law. So that is directly from the DEA's website. They have a practitioner's manual that is essentially what they're looking for. So medical board, this is a medical board case in which we defended a physician who was reported to the medical board. Medical board investigations can be initiated in a number of different ways. They may stem from a coroner's report. A patient or family can complain to the medical board. That, I think, is probably the most typical way that a medical board investigation begins. You might have a colleague that complains about a physician. Pharmacy complaints, when we're talking about prescribing opioids, pharmacy complaints is another way, as well as reporting of malpractice actions, because a lot of states require, when you have a malpractice action against you, a lot of states will require that that be reported to the medical board. So in this case, we had a 48-year-old female patient, and she presented to her internist with complaints of chronic back pain. She was unhappy with her previous physician, and she expressed this to the internist. The internist did not request prior records, and he didn't discuss potential substance abuse with any of her prior providers. He prescribed hydrocodone for her 1 to 2 tablets every 4 hours. And he continued to treat her for her chronic back pain over a 3-year period. 3 years after her initial visit, the patient was seen by a different physician. This time it was a colleague of the internist that she initially saw. And she told this physician that she wanted to get off the hydrocodone gradually. And he counseled the patient about some dosage precautions. And essentially what this patient did then was complain to the medical board, and her complaint was that the provider's poor care led to her opioid addiction. And that is not an uncommon complaint. I do understand the thing that probably triggers in you is the thought of, gosh, doesn't the patient have any responsibility for her own action? And in a lot of cases, that in the end is what will help defend the physician, but this is not an uncommon allegation. We also see it in med mal complaints, not just in medical board actions. So the medical board looked into the case, and some of the things they discovered during their investigation. Again, no pain medication contract with the patient. The chart notes in this case, again, were very brief. There was either a very brief pain assessment or on many visits over the 3-year period, no pain assessment at all. This physician did refer the patient to a neurosurgeon. The patient never went, and the physician never made any attempt to follow up on that. Now, obviously, you cannot force the patient to go to the consultants that you send them to, but you need to do some follow-up. You need to, first of all, find out if the patient went. You need to talk to the patient again about keeping that appointment. And there need to be some consequences. The patient chooses not to keep the appointment, but in this case, this physician for 3 years just continued to prescribe this pain medication without ever really looking into this any further. There were multiple telephone refills in this case where the patient called up, lots of reports of lost medication. Again, my backpack was stolen, the dog ate my homework, whatever. They're just such common issues that these patients will report. The medical board findings included that the physician failed to keep accurate and adequate medical records. He failed to consult prior physicians or review prior records. He failed to consult with or refer the patient to a pain medication specialist, failed to document the actual amounts of the prescriptions in the record, failed to document any risk-benefit discussion with the patient, and failed to document the treatment plan for the patient. And the outcome in this case for the physician was that the physician was placed on monitored probation. His license was placed on monitored probation, and he was required to take a prescribing course and a medical records course. And frankly, under the circumstances, I think that physician got off fairly easily looking at what the issues were in the case. And the one thing I want to mention here is that you want to make sure that your medical malpractice policy has provisions to cover you for an administrative defense. You probably know that certainly a medical malpractice policy won't pay a fine that might be levied against you, but you want to make sure that you have the provisions there that should you need to go before the medical board or have something like that happen, that your malpractice policy will help by providing an attorney, and because you might want to do that. You might need an attorney if you have to go before the medical board. The last area of risk exposure for physicians in prescribing these medications is criminal prosecution. As I said at the beginning, that is a rare thing to happen, but it does happen. The specific charges against physicians may be murder, manslaughter, or drug trafficking. That is essentially the things that you'll see physicians charged with. There was a recent California case, happened in 2012, in which the doctor was charged with the murder of 3 patients. The difference between murder and manslaughter, in a nutshell, I'm not an attorney, but essentially murder is the theory of implied malice, that the physician knew that her prescribing practices were harmful because other patients had died prior to the 3 patients that she was charged with murdering. And so the murder essentially is that you intended to do this. Manslaughter is really, it's a lesser charge, and that is typically saying that the physician, the patient dies, and the physician's responsible for the patient's death because of gross negligence, as opposed to a real intention to harm the patient. And drug trafficking usually involves physicians charged with either illegally prescribing these medications or selling the medications. There are lots of examples of these cases on the DEA website, which is where these cases that I have came from. The first one I thought was pretty interesting because one of the things that we do is we get calls from physicians who are our policyholders asking for risk management advice. And I've taken some calls from physicians who have been approached by these internet companies that would like the physician to provide the prescriptions, to be the prescriber for patients who contact through the internet to get these medications. And physicians need to understand that that scenario is really not legal. The internet company will tell you that you're free and clear because you don't have a physician-patient relationship, because you're never going to meet the patient. The patient's going to fill out a form on the internet and send it in, and you're going to look at the form and write a prescription. And you know, I get the physician will call and they'll say, but the company says I can do this. And I'm like, I don't really care what the company said. I'm telling you, don't do this. It's not legal. The DEA will come after you if they find out. They really spend a lot of time trying to shut these internet operations down. In the case that I read about on the DEA website, essentially there was no contact between the physician and the patient, and that was how it worked. The patient filled out a form, The doctor looked at the form and wrote the prescription. And that particular physician did 25 months in federal prison. A lot of states have very specific laws that indicate that you must establish a physician-patient relationship when you prescribe these medications. California says that there must be an appropriate prior medical examination. Both South Carolina and Georgia have guidelines and rules for prescribing opioids, so you need to also know the regulations in your state. These are pretty extreme cases, as I said. There was another case where the physician was dispensing the pills, and a lot of times they get to these physicians through confidential informants, and the physician sold 500 pills for $500. And that's not an uncommon thing that you read about. The most recent case just happened in May. You may have read this in the papers because it made national headlines. It was a huge case. It's been the DEA's largest operation to date in this arena. It took them over 15 months. It covered 4 southern states. There were 140 arrests made over 15 months of the investigation. And then on May 20th of this year, they did a coordinated effort, and they arrested 280 people in 4 states on one day for inappropriate, illegal prescribing of opioids. And at the time, they were expecting to make about 170 additional arrests. So who was arrested? Who gets arrested in these kind of operations? Physicians, pharmacists, clinic and physician staff also. Typical operation, undercover officers pose as patients, and they try to get the drugs or the prescriptions. They're essentially looking for physicians who prescribe or provide the drugs without examination, without taking a history, without investigating the symptoms or the need for the drugs, where there's lack of documentation, or who prescribe really large quantities of the medications. There's also some cases on the DEA website involving murder. These usually make a big splash. This was a particular case that happened in Nevada, where the physician was prescribing controlled substances to young adults and juveniles without any medical indication. He was going to the patient's homes. He was meeting them in hotels and casinos. It happened in Las Vegas. Some of the young adults overdosed, 1 died, and this physician was found guilty and sentenced to 10 years to life in prison. And again, I think these are fairly egregious cases. These are not really physicians who are practicing medicine, but you can certainly see where this can go when you're not careful. So I want to talk a little bit about relevant laws. And the first laws that you need to know about and comply with when you prescribe opioid medications are the federal laws. Title 21 of the Code of Federal Registry is essentially the place that addresses this on a federal level. And they have a pretty simple description there, that a prescription for controlled substance to be effective must be issued for a legitimate medical purpose by an individual practitioner acting in the usual course of his professional practice. Every state has its own regulations and guidelines for prescribing controlled substances. I specifically researched South Carolina and Georgia because I understood that's where most of the physicians who attend this conference are typically from. The state guidelines are very similar, but you do want to research and find out the guidelines for your specific state wherever you practice. And you can usually find that through either your state medical association or your state board of medicine if you need to find out, where you go to find these. In South Carolina, the Board of Medical Examiners has actually issued pain management guidelines, and many states have done this. The state boards of medicine the governing boards have issued some type of guidelines. In South Carolina, and I want to stop and add that there is a handout that I believe would have been posted with the PowerPoint slide, and it lists the location where you can find these guidelines for South Carolina and Georgia, and some other resources that you might be interested in to get, to find other state guidelines and that type of thing. So in South Carolina, they require an evaluation, a treatment plan, informed consent, and an agreement for treatment, periodic review, consultations as necessary. So they don't require a consultation, but consultations as necessary, accurate and complete medical records, and compliance with applicable laws. So in the cases that we talked about, you can see where the gaps were. And also in South Carolina, physicians need 2 hours of CME in prescribing and monitoring controlled substances. The Georgia Composite Board of Medical Examiners has also issued pain management rules, and their website provides frequently asked questions, which I found really helpful. Some of the things that are required in Georgia: medical history, physical exam, informed consent. They have an emergency provision where you can provide 72 hours of medication without a physical examination. A requirement to obtain prior records, and I thought that was really interesting because that is not something every state has. You may not always be able to obtain prior records, but if you're not successful in doing that, you need to document your efforts. That's what you need to do. So you have to try to get those records, and if you can't get them, document the efforts you made to get them. Referral for substance abuse if the physician determines the patient's abusing the meds, a written treatment agreement, a clinical visit at least every 3 months, and you need to monitor the patient for compliance with the treatment. So they're talking there about drug screens at least 4 times a year, according to the information that I found. Many states have prescription drug monitoring programs. Almost every state has one of these. I've looked up South Carolina and Georgia again. If you practice in another state, there's a website in the resources that is the National Alliance for Model State Drug Laws. It's NAMSDL.org. And on their website, you can find a reference to every state's prescription drug monitoring program. So if you want information about other states, you can get it there. These programs are very similar. Again, every state sets their own rules. Typically speaking, and this is true in South Carolina and Georgia, the dispensers are required to report. That means the pharmacy. If you as a physician dispense, then you would probably be required to report also. But whoever dispenses medications are required to report to these databases. In South Carolina and Georgia, the physician may access the database. In some states, the physician is required to access the database. They're great tools for you when you prescribe these medications, that you can find out where all this patient has been obtaining medications, who they've been obtaining them from, what medications, the amounts of medications, the dosage, and that, and so on. The states that require you to check their databases typically require you to check it before you start the patient on treatment and then periodically during the treatment. Certainly if you suspect abuse, but at least initially and then periodically, either once or twice a year. So let's talk risk management recommendations, and I think that some of these are fairly obvious from the cases that we looked at and some of the things that we've already talked about. Certainly you need to have a comprehensive medical examination, and it needs to be well documented in the medical record. Any appropriate diagnostic tests need to be done. So again, I'm not saying you must do diagnostic tests, but they're going to look to see if appropriate diagnostic tests have been done. There should be a written treatment plan. What is it that you want to achieve with this patient? You need to do a objective, comprehensive pain assessment. The use of some type of tool can be helpful. This is one example of a pain assessment tool that sort of breaks it down to the most simplistic form. A lot of times it's simply, where's your pain on a 1 to 10 scale, but you need to use a consistent way of assessing this so that you can do that at every patient visit and see where the patient is going with this. You want to request copies of previous records. You want to do whatever you can do to get those, and you want to document if you're not able to get them. You want to reevaluate and document that patient's pain level frequently during their care and treatment. Certainly note the effectiveness of the treatment. If the treatment is ineffective, you want to note what's the patient's response. If you're going to change treatment, you want to note your clinical rationale. And as a risk management professional, that's really important to us. If you get into trouble down the line, if the patient gets into trouble and you get involved in a lawsuit, one of the things that you're going to be asked is why. Why did you do this? Why did you prescribe more? Why did you add this other medication? And you want to make sure that you remember 2 or 5 years down the line why you did that. So documenting the rationale for changes is helpful. You want to utilize specialists when that's appropriate. One of the things you want to do when you prescribe these medications is find out what's available in your area. Find out, do you have pain management specialists you can use? Are there orthopedic surgeons that you can refer patients to? Where are the drug treatment centers? Where are places you can refer patients to who have problems with these medications? Kind of get yourself armed with that information so that you have it available to you when you treat these patients. And of course, I can't stress the documentation in the cases that we looked at here. Very poor documentation, which led to some of the problems as well as led to a difficulty in defending the care. Certainly, you want to try both pharmacological and non-pharmacological treatments. You want to follow pain management guidelines. There are several different organizations out there that have established guidelines, so you want to get familiar with those and follow the guidelines. And you want to, make sure that you document. You want to communicate with other providers who are treating the patients. So not just getting prior records, but when you know that the patient is seeing an orthopedic surgeon on an ongoing basis or seeing a psychiatrist, get what information you can and communicate. Make sure that physician knows what you're prescribing and you know what they're prescribing. And certainly utilize the physician drug monitoring program in your state. So I want to talk for just a minute about drug-seeking behavior. Any ideas on what some of the red flags are? You can just, if you have patients that have done these things. Frequent visits. Anything else?
I lost my PCP, and you have to help me out until I can find a new one. That may be months to years, right?
Yeah, that's a good one. Yes?
Yeah, my car got broken into. All I asked him was, will you bring me the police report, then we'll talk.
Love it. Yes. Yes. I lost my backpack. Yes, go ahead. Yes. Yes. Anything else? Yes.
They smell the drug they want.
Love it. The only one that works, right?
For the gynecologist, it's usually a long search for history. Anybody who's had multiple diagnostic labs and they chronic pain, the diagnostic labs, endometriosis, family history of endometriosis. Not that they may not.
Right.
But
right.
Those are all sets of red flags.
And that's the thing with this. You do have to be careful because seeing one or more of these red flags is not an absolute indicator that a patient is abusing, but it is something that should make you investigate a little more closely. Some other things, patients who see multiple physicians for the same problems or who have seen multiple physicians in the past, when you're not able to get medical records, that might be an indicator. Like she said, I lost my PCP. My last 3 physicians closed their practice. There are no medical records. I've actually seen physicians make it a requirement of treatment that if they're going to treat pain, they must have old medical records, period, end. Failure to follow through with other treatment recommendations that you make is a red flag. So when you want these patients to go to physical therapy, see a neurologist, see an orthopedic surgeon, and they just don't, that's a red flag. The calls for early refills, which is where sort of the funny stories come in, but they all have, I mean, this is a population that loses their backpack more than anybody in the world. Another thing to consider is cash only. People who don't want to use their insurance for this, they want to pay cash for these visits, is another possible red flag. So some of the things that you want to do here, yes, sir.
If they start out telling me how good of a doctor you are, usually it's a setup. Because I've heard good things about you and I wanted to come and see you, and then they go straight for the medicine at the end.
Yeah. I get a little suspicious of. I've actually seen some physicians who draw patients from extremely far geographical areas to come see them for their pain management. And it always makes me just a little suspicious, because I wonder, why is a patient traveling hundreds of miles to see this physician for these prescriptions? So that's more of a red flag on the physician, though, than the patient. So you certainly want to understand what these red flags are. You want to understand what the indicators are for drug abuse. You need to set limits with your patient. Notice the frequency that the patients request refills. And I think that a pain medication agreement is one way that you can really control some of this. It helps you set up the expectations ahead of time. It's a great facilitator for your informed consent discussion and your patient education. It doesn't take the place of talking to the patient, but it's a great facilitator for that. You want to make sure it's understandable to the patient. Non-compliance with elements of the agreement can help you diagnose drug addiction, can help you pinpoint misuse or abuse. And this agreement should include the consequences for the breach of the agreement. And for most physicians, there's no leeway here. You break this agreement, I don't prescribe these medications for you. This is absolute. You need to apply it consistently. As I said before, we get a lot of calls from physicians asking risk management advice. And I'm always sad when a physician says, these are all the things this patient has done that I'm prescribing this medication for. And one of the first questions I ask is, do you have a pain medication agreement? And when they say no, you don't have as much to use. If you have a pain medication agreement and the patient has broken that agreement, you know where to go with that. There's no question. They haven't fulfilled it. Some physicians may give one chance. Some physicians may give none. Elements in the agreement, it lists the things the patient agrees to tell the physician. For example, the patient agrees to give the physician his or her history. The patient agrees to tell the physician what medications they take. The patient agrees to tell the physician if he has to go to the ER. And it establishes your expectations. Then if you discover that the patient has done these things and hasn't told you, you have this agreement to back you up. It states the patients won't share, sell, or trade their meds. It states that the patient won't ask for early refills, that the patient will get these meds from only one physician, and some physicians demand that they use only one pharmacy. And it also typically will involve the use of drug testing with patients. Some other things you want to, today we're doing a lot of electronic prescribing. Some states don't allow electronic prescribing of narcotics yet, although I think we're moving in that direction. If you are writing out prescriptions, you want to make sure that you write the numbers out in words, because that's more difficult for a patient to change. Make sure your prescription pads are protected. Hate to walk into an exam room and find a stack of prescription pads laying on the table, because your staff brings the patient in there and sets the patient up and closes the door. So you want to keep those protected. In your pocket, in a locked drawer in your desk, under the control of an office manager, some way not available to the patients. If you are aware that there's been diversion or fraud, or you know a patient has forged your signature on a prescription, we typically recommend that you do notify law enforcement and let them know about this. That's a frequent call we get. Physicians are always a little concerned about a HIPAA violation, and you might want to call your med-mal carrier or an attorney to get some advice, but typically when you know there's been fraud or abuse, you want to report that to the authorities, and you want to make sure that you do good documentation when you prescribe these medications. When push comes to shove, you might need to consider terminating the patient relationship. I typically consider that to be a last resort, but issues with pain medication is one of the reasons that physicians often choose to terminate a relationship. You want to make sure that you do that appropriately. Usually requires that you provide that information to the patient in writing, that you give the patient some notice so that they have a chance to find another physician. A few states may have requirements for how much notice. Typically it's 30 days. I have seen some physicians give 2 weeks notice. I've seen some give longer. Some of it depends on where you practice, how difficult it is for a patient to find another physician. During that notice period, you should provide medical care to the patient, not just for emergencies or urgent needs, but you are still the physician until that date when you've severed the relationship. But I do always tell physicians that they don't have to prescribe anything they're not comfortable prescribing. So just because the patient walks in and demands the specific medication that they know how to spell and they want this much of it and these many pills, you're not required to do that. You still have to use your medical judgment. There are issues with detox, certainly when patients are on large amounts of these medications, and you do have to be cognizant of that. But when it comes down to it, you're not required to prescribe anything that you do not feel is not medically necessary. So basically, most physicians really are trying to do the right thing to control patients' pain. To improve the safety of the patients and to reduce your own liability exposure, you need to become knowledgeable and follow pain management guidelines, take some preventative steps, consider implementing some of the risk management recommendations that we talked about, and that can help keep your patients safe and help you stay in compliance with federal and state laws and guidelines and avoid claims, make your care and treatment more defensible if you do become involved in a claim. So I think we have a few minutes for questions. Yes? You know, that's an interesting question, and for those of you who might not have heard, the question was, you know, what about patients who test positive for marijuana? Generally speaking, in a pain medication agreement, the patient would agree not to use any illegal substance. So one question I would ask is medical marijuana legal in the state where you practice?
No, but what we do is if you test positive once, we give you the second chance. If you test positive twice, you're done.
And again, to repeat that, she says that, you know, if the patient tests positive once, they do give them a second chance, and if they test positive the second time, they're done. And, you know, I think that's a valid way to operate. You want to make sure the patient knows that up front. In a pain medication agreement, you'll usually ask the patient to state that they won't use illegal drugs. Now, if you operate in a state where medical marijuana is legal. That's a whole other discussion that we probably don't have time to get into this morning because I have to be done by 8 o'clock. But, you know, that has to be factored in, so that might change some things if you are in such a state and you know that the patient is using medical marijuana. So, you know, I would just ask that you do consider that. Yes?
I've done emergency medicine for 37 years this year, and I would just like you to share what we've been through in Florida, where in 2009, we had 90 of the top 100 prescribing physicians for oxycodone and pain medications, and 49 of the top 50 dispensing pharmacies for narcotics. We had 10 deaths per day in the state of Florida due to narcotic pain prescription overdoses. And our Attorney General and Governor went after this situation, established really serious regulations of pain management clinics. They had in the past had trouble prosecuting physicians. Now these are small numbers, guys. These are 90 doctors out of 27,000 doctors in Florida, but still a significant number. And we now have decreased the number of deaths due to pain medication to 1 per day. Still too many, but not nearly the area. So when she showed that slide of 4 states that just had a sting operation, I was very proud to see 4 of them in New York.
Yeah, it's a huge issue, and you know, as an ER physician, one of the things you probably see is that a lot of times these patients end up in the ER when they can't get the prescription from a primary care physician or a PCP.
My deal is, I say the state doesn't let me prescribe large amounts. I will prescribe a very small number for patients who can show me they were on something. I will give them, it's always a weekend, can't get the doctor,
Yeah.
and I will give them 3 days, which is 10 pills, and I say that's it. Don't come back, because that's all I am allowed to do. I don't feel I am endangering any lives by doing that, and I feel I am taking the patient's pain complaint seriously.
Right. And, you know, one of the questions we field a lot of times is, in an ER, can you just post a sign that says we won't prescribe pain medication? And that is controversial in that it has been considered to be an EMTALA violation when you do that in an ER. So that's something that you have to be careful of there. Yes?
I suspect addiction, I would sometimes call the pharmacist, and on the phone, I'm saying, okay, they've got this prescription, and they're discovering, oh, well, they got it from so-and-so, and then 2 weeks later, they got it from so-and-so. And my question is, what obligation do they have to call us and say, you know, this is the 3rd prescription?
Okay, so the question, I'll repeat that in case anybody didn't hear it. Does the pharmacy have some obligation to let you as a prescribing physician know that, you know, this is the 3rd prescription this patient's walked into the pharmacy with in several weeks or a month? And, you know, I don't really believe there's a legal obligation there, and that's where your physician drug monitoring program in the state where you work can help you out, because depending on the state, and like I said, almost every state has this. I live in Pennsylvania, and we have not had this that's been accessible to physicians. They're just now implementing it. We're one of the last states that have implemented this. But if you have this in the state where you live, it is a great thing to do, because you check it and you see who all has been providing these medications for the patients. So, you know, it puts you in a position where you don't have to even call that pharmacy, because that patient could be getting them from multiple pharmacies, and so calling one pharmacy doesn't help you. Yes, in the back.
So there's a hole in the prescription drug monitoring program in that it's not national. So I live in a state that's close to 2 other states, and patients cross state lines, so you don't know if they're getting a prescription from another provider, even if you check your state's drug monitoring program. So how close are we getting to a national?
You know, I don't really see any movement yet in having a national program. I know I've seen some of the states I've researched will allow you to access if you practice in a neighboring state. Now that's more of a burden on you because that then gives you multiple states that you have to check. Most of the states' programs will allow you to assign a staff member to access the database. In states that require physicians to use the databases, you can typically assign a staff member to access and pull the report, but you as the physician still need to review that report. So that is something you can get a staff member set up to get into them. Most of them are just worked online. But yeah, I think when we have almost every state with one of these programs now, so my suspicion is that some kind of reciprocity like that will come, but I haven't seen anything discussed.
There is some reciprocity with states. So if you go on Mississippi, which is where I am, it lists the states where there's reciprocity. And there's like, I don't know, maybe 6 or 8 states that do provide information to other states.
Mm-hmm.
None of them are close to mine, so I don't ever see patients getting prescriptions out of Missouri when they're in Mississippi.
You need to work with your state medical boards and get them working on this to get everybody working together. Yes, sir?
Are you breaking any laws if you call a pharmacist and ask about a patient?
Are you breaking a law if you call a pharmacist and ask about a patient? You're talking HIPAA, I think, here. No, because it's going to be your patient. You're not calling about the man who lives next door just because you're curious. This is your established patient. They will talk to you about that. They should be talking to you about that. Yeah, you can do that without the patient's consent. You don't need the patient's authorization to exchange health care information with another provider, and a pharmacy is another provider.